Great. Okay, terrific. So welcome everyone. My name is Amy Harris. I'm the manager of the Patient-Centered Primary Care Home Program. And you're joining us today for this webinar about PCPCH Standard 6E, which is Cultural Responsiveness of the Workforce. And this is a standard that will be in our 2025 revised standards that will be implemented in January of next year. So we're going to talk with you about this today. It's part of our series that we've been doing since April. If you've missed any of the webinars, we do them every other Friday. If you've missed any of them, they're all recorded and on our website. Oh,
Oops.
it looks like Susan might have dropped off. Susan was doing our screen sharing. Okay, well, let me pull up the slides. Unless Rachel, are you in a position to pull the slides up? If not, I can advance them. Sorry about that. Technical.
No worries.
Do you want me to do it, Rachel?
No, I can do it.
Okay, terrific. Okay,
Yeah.
good.
Let me just present. There we go.
We've been having a lot of technical stuff today. In fact, one of our presenters, Alicia, her camera's been going in and out. So we'll see what happens today, you guys. It could be a fun one. Okay, great. Thank you, Rachel, so much. So with that, I'm going to just turn it over to Alicia and Kamar, who are going to present on the standard.
Great. Thank you, Amy. So good afternoon, everyone. My name is Alicia Tavares, and I'm a verification specialist for the Patient-Centered Primary Care Home Program.
And I'm Kamar Haji Mohammed, an improvement specialist, one of the site visitors.
First, just a few webinar logistics and Zoom etiquette reminders. This webinar will be recorded and uploaded to the PCPCH program website. If you are having any technical difficulties, please private message Amy Harris for help. If you feel comfortable, please have your camera on and put your name and organization info up. Any questions or comments you have can be put into the chat and we will answer them during the question session. Here is the agenda for today's webinar. I'm going to start by providing a brief overview of the 2025 PCPCH recognition criteria. Next, we will deep dive into PCPCH Standard 6E, Cultural Responsiveness of Workforce. Next, we will share additional PCPCH resources and upcoming learning collaboratives. Lastly, we will have some time for your questions. The Patient-Centered Primary Care Home Program was established in 2009 by the Oregon Legislature as part of the state's broader health system transformation strategy to improve access to care, reduce costs for patients, and improve population health. The standards are developed in partnership with an advisory committee and have been revised 5 times since 2009. The 2025 PCPCH standards were developed to support OHA's strategic goal of eliminating health inequities by 2030. The standards specifically help primary care practice build their capacity and processes to address inequities in their patient population. All practices applying or reapplying for PCPCH recognition after January 1st, 2025 must meet these new standards. For more information, I would encourage you to watch the recording of the 2025 PCPCH Standards Overview webinar, which is on our website. Today, we are going to review PCPCH Standard 6E. This is a new standard in the 2025 recognition criteria. PCPCH Standard 6E is in core attribute 6, which from the patient's perspective means recognize that we are the most important part of the care team. We received feedback from our community listening sessions that highlighted a lack of culturally responsive care, including issues like insufficient culturally specific referrals, underrepresentation, and misunderstandings of patient values, all of which reduce patient trust. This feedback was a key reason for adding the standard to our 2025 Technical Assistance Guide. The intent of Standard 6E is that a patient's background, culture, identity, and social circumstances can significantly impact their health-related priorities, trust for their medical home, and overall experiences with primary care. This standard aims for PCPCHs to take steps to understand their patient population and deliver care in a way that is culturally responsive, trauma-informed, and improves overall trust. For Standard 6E, we have added a new PCPCH must-pass measure. There are two measures in Standard 6E. The first measure, 6E0. PCPCH assures that its staff is trained in delivering culturally and linguistically appropriate, trauma-informed, or trust-building care. This is a new must-pass measure worth 0 points. The second measure is 6E3. PCPCH partners with one or more traditional health workers or traditional health worker services. This measure is worth 15 points.
Great, thanks, Alicia. I'll discuss both measures in detail, beginning with measure 6E0. A practice is meeting this measure if it assures that each of its primary care providers have undergone training in delivering culturally and linguistically appropriate, trauma-informed, or trust-building care within the last 2 years. Training should be tailored to the unique patient population of the practice, emphasizing how patients' backgrounds, cultures, identities, and social circumstances influence their healthcare experiences and priorities. Practices may provide this training internally or partner with external organizations. Here are a few examples of how to implement this measure in your practice. Additional examples are available on page 159 of the TA Guide. A practice requires that all its primary care providers take a virtual training on how to deliver trauma-informed care at least once every 2 years. Another one can be, as part of a new employee training, a rural practice has developed its own training for its primary care providers on the barriers and priorities that local patients face around transportation and food insecurity, and how to engage patients in discussions about self-management in a way that acknowledges their immediate priorities. The practice offers a refresher training every 2 years for its primary care providers that already received the initial training. When completing your PCPCH application, we strongly recommend gathering all documentation needed for a site visit. For measure 6E0, ensure you have the following document ready: policy, procedure, or workflow demonstrating the type of training that the primary care providers receive, including the topic, source, and when this training is administered. On to measure 6E3. A practice meets this measure if it partners with one or more traditional health workers or THW services to deliver patient care. Below is a list of traditional health worker types: community health workers, personal health navigators, birth doulas, peer support specialists, including family support specialists, youth support specialists, recovery peers, and mental health peers, and peer wellness specialist or other similar roles. Practices can choose to either partner with external THW or integrate them into the practice, but must be able to demonstrate that the THW has been trained or credentialed according to their role. Practices may, for example, require that their THWs are certified by the Oregon Health Authority or under a similar program, or may have their own unique training requirements for THWs. Staff serving as THWs may have other roles at the practice, so long as they have been trained or certified as a THW and are delivering THW.
Uh-oh, we can't hear you.
I think I said at the top of the call that at the top of the webinar that this might be a technically challenging one. We've had a lot of,
I feel like
oh, you're back,
Oh,
Kumar.
you're back.
okay,
Okay.
okay, I'm sorry.
No, that's okay. It's
Okay, Yeah, so I'm not sure what's happening. Can you hear me okay now?
Yes.
Okay, perfect. So, and then next slide, or were we still on this slide? Did I not cover this one? Should I go back to this?
I think maybe the last couple sentences. We didn't
Okay,
hear.
so staff serving as THWs may have other roles at the practice so long as they have been trained or certified as a THW and are receiving or delivering THW services to their patients on an ongoing basis. Okay, next. Here are a couple of examples on how to implement measure 6E3 in your practice. A women's health center hires 3 part-time doulas, offering to pay the credentialing fees for those who are not yet certified with the OHA to ensure that all doulas are credentialed within 2 years. Another way could be a practice determines that its low-income patients are having difficulties navigating their services, and that the community health worker could improve quality of care, use of preventative services, and adherence to treatment. The practice partners with their local coordinated care organization to provide CHW services to their OHP patients on a weekly basis. And also more examples can be found on page 161 of the TA guide. There are 3 types of documentations that are required at a site visit for measure 6E3. Either a THW job description or evidence of workflow involving THW services, data demonstrating THW caseload, and evidence of THW credentials or training plan. And I'll hand it over to Alicia.
Thanks, Kamar. The PCPCH program is hosting this webinar series to assist practices and other community partners in understanding the standards. Webinars are scheduled every other Friday through December. You can find a complete list of topics and registration information on our website. The next 3 webinars are listed on the slide. I hope you'll join us, but webinars will be recorded and posted on our website if you can't make it. This final slide is additional resources that you may find helpful. The first is our PCPCH program website. The second is the 2025 TA guide with detailed information about how to implement every measure and the documentation requirements. Next is a link to our TA resources webpage. And finally, the community engagement report and evaluation. Lastly, you are always welcome to reach out to the PCPCH program with any questions through our program email.
Great. Thank you so much, Alicia and Kamar. So before we dive into your questions, it looks like there's already a couple in the chat, which is great. I just want to let folks know that this is, so 6E0, the must-pass measure, it is a new measure. And if you've participated in the program for any amount of time, which I know probably everyone on this call has, you know that we have never actually introduced a new measure as a must-pass measure. We usually make the measure an optional measure and one that practices can choose to attest to or not. But in this particular case, the Standards Advisory Committee, who helped us create and develop the revisions to the model, really felt like it was important that we have a must-pass measure that focused on equity. And so this is that measure. And so I would say that as you'll see, if you have had a chance to read the technical specifications, or as Alicia described, there is a lot of flexibility in the types of trainings that you could use to meet this measure. Again, it's new, it's a must pass. We know that makes, we know must passes make people feel a little bit uncomfortable. And so we just want to make sure that it's understood that we're really flexible on how you're reading it. We just want to see that you're doing some kind of training for at minimum your clinicians, but also ideally for your whole practice. So I just want to say that as well. I know it might feel a little bit strange to have a new have a measure that's a must pass. It's a brand new measure. So with that, I'm going to open it up to questions, and we'll just go through what's in the chat. So and if you have a question, you're welcome to pop it in the chat. You can also unmute yourself if you want to and speak, or raise your hand. Okay, so let's roll up to the top here. So one of the questions that was asked that was actually covered in the presentation, somebody was jumping ahead there, Megan was jumping ahead, asking if a community health worker was a traditional health worker, and the answer is yes, as you heard in the presentation. A community health worker is one category of traditional health worker. Traditional health worker is the umbrella term. And there are different types of traditional health workers, and community health worker is one, as well as doulas and peer support specialists and patient health navigators, all of which you heard about. So working with any of those types of traditional health workers would qualify for this standard. So you don't have to be working necessarily with community health workers. You could work with doulas or peers or whatever makes the most sense for your patient population. So I would really encourage folks to take a look at that list and take a look at those types of providers that fall into that category if you're thinking about this measure, and really think about which would make the most sense for your patient population. So that was a good question. So let's see, another question is, do you have recommendations for how we can find what other providers are doing in our community so we can partner with them for traditional health worker services? So that's the first part of the question. So this work is pretty new in general. So I would say my first reaction would be to reach out to your CCO, because CCOs are also doing some work in this area. I don't know if folks have other ideas or resources. That's my initial reaction, is to reach out to your CCO. I don't know, staff on the team, do you know where people might find out about other organizations or practices doing this work?
Hi, this is Meg. I can tell you that each CCO has a local community advisory council, or an LCAC, or LCHIP is what they're called now, I guess. You can go to that group, and they will actually be applying for grants every year based upon performance in your area. And I know in my local area, that's how we had some CHWs funded, was through grant work through the CCO. So thanks.
That's great. Thank you, Meg. And it looks like Andrea has raised their hand, and Andrea in their description says that they're a THW liaison for Umpqua. So we're definitely going to see if Andrea has a question or comment about that. Thank you for chiming in.
I actually can help with that question a little bit. So I'm a THW liaison with Umpqua Health in Douglas County. And all of the CCOs in Oregon have THW liaisons. It's written into legislation. It's required for all CCOs to have one. What our role is basically to work on integration and utilization issues for traditional health workers throughout our respective areas. So for organizations looking to hire traditional health workers, you should reach out to your THW liaison at your CCO. It's going to be different at every CCO. Some of us this is our whole role, some are combined role. But our whole job is to help you figure out how to hire traditional health workers in your agencies, how to fund them, what payment mechanisms help fund them, where to find them, where to hire them, how to train them, how to certify them. Like, that's our entire role. So definitely reach out to your CCO. Some CCOs have incentives for hiring traditional health workers and help absorb some of those costs. But yes, that would be my recommendation. Reach out to your CCO. We're here. So, and I'm the one for Douglas County for anybody who needs that help. So
great.
That's it.
Thank you so much. I'm so grateful that you joined today and added that additional of information. We may call on you for other questions, so stand by. So
Yeah,
thank you so much.
I just wanted to add, Amy, this is specific to CHW, so not necessarily the THW, but ORCHWA. Some of you may be familiar. I'll just put the link, their website online, but they do have a lot of information, and I know that they're in different regions all throughout Oregon. So if you can contact, if you're interested to partner specifically with community health workers. But I know sometimes they have information for doulas and things like that, but they really do specialize in community health workers. So that might be another avenue as well. Just wanted to add that.
Thank you for that, Kamar. I forgot about Orchwa. They're actually a great resource for community health workers, so I appreciate that. Great. Okay, so let's move on to that question was a two-parter. So here's the second part. Okay, so the traditional health worker can bill for services, correct? Also, is it an expectation that each clinic pay for the traditional health worker as well? How do we find out more about that information? So yes, they can bill for services in their CCO. So the CCO will cover traditional health worker services. I'm not sure I understand your question about, is it an expectation that each clinic pay for the traditional health worker? For our program, for the PCPCH program, we don't have an expectation that each clinic hire their own THW. In fact, oftentimes that's not necessarily best practice or like the preferred practice of traditional health workers. You can certainly use community-based traditional health workers, or partner with other organizations to meet those needs of your patient. So that's not a requirement for our program. I'm not sure if that was what you meant by that question, but it's not an expectation from our clinic. And then more information about billing. I mean, I guess I would actually defer to Andrea again, since she's the THW liaison. I don't know, Andrea, do you have anything to chime in about with that? That'd be great.
There are actually quite a few different payment mechanisms for THWs. Definitely fee for service. They can bill for their services. Everyone except for the personal health navigators. Personal health navigators, there are currently no CPT codes that exist for that worker type. But all the other worker types are able to bill for services. There's also a subsection of the ILOS in lieu of services funding that pertains to community health workers. So that's a funding mechanism. There's grants. There's lots and lots of different funding mechanisms. Some people are using traditional health workers for their HRSN services. So there's lots and lots of different mechanisms. So again, your THW liaison is going to be the source of all information pertaining to those sort of things, and they can really help you take that look specifically at your organization and what payment structures are going to work best for you, what worker types are going to work best for you. I can tell you that most agencies that utilize THWs hire them like within their own agencies using these different funding mechanisms rather than contracting out to other agencies. So that makes sense.
Great. Thank you so much. Again, happy you joined. And obviously, I think the key message is here is that, reach out to your CCO about funding as well. And each CCO is structured a bit differently, but they, as Andrea said, they all have a liaison. So, and if folks are having trouble figuring out who that liaison might be, you can definitely reach out to the PCPCH program, and I can confer with my colleagues who work directly with CCOs, and we can get you the contact person at whatever CCO you're interested in reaching out to about the liaison. Except Andrea, we know Andrea. So great, thank you so much. Let's see, are there any on-site requirements for the traditional health worker services? So as I stated before, no, we're just really looking that you're partnering with either a traditional health worker, one of the people in those categories, or an organization that provides those services. So for your patients, it does have to be for your patients, but no, but it doesn't have to be, you don't have to hire them. It doesn't have to be on-site. Let's see, are any practices here doing anything that would qualify for 6E3? I'd love to hear some more examples. That's a great question. I don't know if anybody on the call would like to unmute themselves and share how you might be using traditional health workers currently, or maybe what your plan is to utilize traditional health workers. If not, I think our team can probably come up with some examples as well from what we've seen at verification site visits, but I'll open it up to the group here first and see if anybody has anything they'd like to share.
At Legacy, we had Health Navigators that were kind of regionally in clinics, especially in our Silverton region, and we just kind of evaluated their roles, and essentially they just were like they were basically doing the work of a community health worker. And so we evaluated their roles, and now we're going to move them into the community health worker role. We are building their workflows now, though. So if anybody has any good workflows for community health workers, please put them in the chat because we need some help on those for sure.
I was trying to unmute myself, but didn't work. Thank you for sharing that, Amber. I think that that would be a real benefit if anybody has those workflows. I think there are a lot of practices that are probably in the same boat where they really are working on developing those workflows now. So well, that's great.
I'll
We
just
can see.
add,
Okay.
yeah, my site visit partner and I recently did a site visit where they had a community health worker integrated into their clinic. It was a clinic in Bend, so rural-ish, I guess. I'm not sure Bend is still considered rural, but they had their person, so every morning huddle, so he was there for morning huddles, so he could see what patients were coming in to kind of build his schedule for the day and maybe know and anticipate when a patient might be needing him for that warm handoff. He also did chart scrubbing to look through a patient's chart that was coming in to see if there was anything that they might anticipate before the patient came in. But he also spoke of helping patients with their medications, the cost for medications, insurance, signing up for insurance, helping with transportation needs, did outreach to the community. So, in Bend in the winters, it can get pretty cold. So, preparing folks with solar chargers and propane for heating in the winter, taking food out to their patients that were houseless. Food bank, Veggie RX, working on getting financial assistance, hooking up patients with cell phones. So that was kind of all the work that person was doing for patients in the clinic, which kind of was different from maybe the care coordination piece or behavioral health piece. So this was another person that was actually going out into the community and meeting folks where they're at to provide those services.
If I may jump on that, if that's okay. I was going to say, in addition to that, so it really depends on the role that you have and what's best for your patient population. And I worked as a community health worker at a clinic hired by the clinic, the system. They also trained us. We got credentialed and they paid for the fee and so forth. So really, you can think of it. I always described my role as a liaison between the community, anything to do outside of the medical kind of system, and the staff or clinicians in the clinic. It was so broad. It really depended on the patient themselves. One was educating on diabetes or nutrition. We had nutrition classes. Another one was specific to school system because they were having issues in school. Another one could be, financial, as Amber said. Other ones was really they wanted to find. I remember because the area that we just stayed in is like where can we walk? We don't really have ideas of where to walk in my neighborhood. So really I was just mapping where they could get their address and things like that. So there's so many things that as a community health worker I was able to do for a patient, and it really varied for sure. So yeah, many different ways, again depending on the role of the THW for your patient population. But yes, various ways. So open. So excited for this standard, just to say.
Yeah. Thank you so much, Kamar and Amber, for sharing those things, that additional information. And it looks like maybe Andrea has something to add as well. So if you want to unmute yourself, Andrea. Oh, you're still muted. I think you unraised your hand but didn't unmute. I've done that before.
Oh, Chris. Okay, so I worked as a community health worker and a peer support specialist. I'm dual certified in both prior to working for Umpqua. And one of the things that I was utilized for when I worked at Peace Health was I was hired as a community health worker for inpatient psychiatric. And my goal was to work on ED utilization, so readmissions. So specifically, I was assigned to work on that metric, work with patients who had really, really high ED utilization. So I was responsible for identifying who those patients were and meeting them in the community wherever they were, whether they were in jail, whether it was at their home, whether it was at their primary care clinic, whether it was mental health court, or, wherever it is that the patient was at, that's where I would go. So we're really, traditional health workers are kind of meant to be boots on the ground sort of workers. We've existed for centuries before there were titles for our roles, before there were certifications for our roles. We're really meant to be out in the community, a trusted member of the community. People interact with us differently than they would with their clinicians. And really, that's what you need to be looking at your traditional health workers as, is we're there to tackle the social determinants of health. We're there to break down barriers, increase communication and connections between the providers and their patients. So if you can think of it, that's what we do. So one thing I do want to say is that one of the things they teach us as community health workers is we talk about the dimensions of wellness. So that's why you won't often see our roles limited to just being in a clinic, in an office, because we're looking at, okay, our patient is having financial challenges. Our patient has mold growing in their apartment. Our patient has transportation issues. Our patient has legal issues. Our patient has all of these different things that we're there to help them kind of break down those barriers to achieving overall wellness, if that makes sense. So you can think of it, we can probably do it.
That's great. Thank you so much for sharing your personal experience with that as well. So, it looks like Jacqueline, you have something to add as well.
Yes. So I'm from Multnomah County Multnomah County Health Department, but we have clinics all throughout the Multnomah County area. We have 7 primary care clinics and 9 student health centers. And we have a really robust community health worker team. We have 2 supervisors and I think 12 or 14 community health workers. So we have quite a few, and they are embedded in the clinics. And what Kamar and Andrea both alluded to, like basically our community health workers meet folks where they're at, whatever the need is. In the past, they've done cooking classes, nutrition classes, walking groups, some of that sort of tapered off a little bit during COVID, but is back up. We back into utilization. We also do CSA events. So we've partnered with farms in the area so that people can come and pick up fresh produce. We partnered with a bike program. I can't remember the name of it. I'm not like super connected to this work, but to make sure that people had bikes accessible to them so that they could ride with their families, or they could use the bicycles to go pick up produce or to get to appointments. So I think, like what Andrea said, anything that you can imagine, like people are constantly coming up with ideas, and really they take so much input from the patients, like asking them what they need instead of us telling them what they need, which I think is like really the beauty of community health workers. Just those relationships and helping people to feel comfortable, meeting them where they're at, communicating to them in, their primary language, understanding their culture and what those needs are. I just think there's such an important part of healthcare, and I'm glad this is a must pass, even though I'm sure it's like challenging for people to get started. But this program has been around for quite some time. I remember going to some of the really early meetings when the state was starting to really certify, and just how exciting that is. because I think people are comfortable with our community health workers. You know, we learn a lot about their health and they communicate a lot back to the medical teams that you don't get in a 15-minute or 30-minute medical appointment, right? So when you talk about the wellness and health of our patients, like, it just seems like such an, almost like a health doula, right? Or a wellness coach. It's like a very essential and like integral part of like our healthcare. We do warm handoffs. They help us with, they're embedded in our diabetes education work and management work. I'm just thinking of all the things. There's a long list, but I would be happy to gather up some information. And we've been working, of course, closely with Alicia and Kamar for site visits and just pass some of that along to you guys, because I think it's really helpful to not have to build those out yourself. And as the largest health center in Oregon, it seems like the right thing to do. So I will see if I can gather some of that information and share that with this group.
That would be great. Thank you so much for sharing all that and for the offer to share those resources. And I do, as everyone was sharing, I was thinking like maybe we should do a learning collaborative around this topic, like around because you know we know that anyway, we will go back and discuss that with the team. But I already see the team nodding their head. So so I would say there's a pretty high likelihood that we'll do some kind of some kind of shared learning around that for sure. And we would try to tailor that to all different practice sizes and types. So like, I know sometimes like it's different, like resources that are available in Multnomah County might be different than what would be available in like a small rural clinic. So we would make sure that we had really good representation from different practice types when we do that shared learning. So yeah, so thank you. Thank you, everyone.
Yeah. And we also document in Epic and use Epic to track those, track the appointments and the connections and everything. And I do believe we're billing for those also, or we just started billing within the last year or so. So yeah, I think there's a lot of information that we could definitely share and a lot that we could learn from other community partners that are doing different things than we've thought of. I think that would be great.
Yeah, that's great. That's great. Thank you so much, everyone. Okay, so let's move on to the next question. So it says, somebody asked what we mean by provider in the technical specifications. This is for 6E0, which is the training requirement, the must-pass measure around training. For now, we are really only requiring that primary care providers are trained, but we would really encourage you to train as many people in your clinic as you can. The rest of your staff who interacts with patients, as well as your administrative staff. We will eventually be requiring that in the program, but because this is a new measure, we did want to make the ramp up a little easier, but we would really encourage you to look at making sure that your entire clinic staff was trained. But that's a good question. For now, to meet the must-pass requirement, it's just primary care providers. The next question is, does the traditional health worker have to be OHA endorsed or like registered to count for this measure? So we don't require that your traditional health worker be registered or trained or certified by OHA because we do know that there's lots of different ways that traditional health workers are utilized. I will say, and Andrea, you can probably correct me, but I believe that for payment purposes, they do need to be certified by OHA. So if you are submitting reimbursement or payment from your CCO, they do need to be certified by OHA. Is that correct, Andrea? I'm like 90% sure it's correct, but I'm asking the expert.
Yes, it is.
Yeah,
and
good.
the CCOs all have metrics tied to traditional health workers. And in order for them to qualify for those metrics, they have to be a certified traditional health worker. I could tell you that although the training programs, there's generally a cost, there's no cost generally associated with OHA's certification process. So
Good. Thank you for that.
Note.
Yeah. So again, this would be another reason to reach out to your CCO because, as Andrea said, there is an incentive metric for the CCOs that is tied to utilizing traditional health workers that are certified. So they could perhaps provide you some support and some resources to get perhaps workers that you already have on staff to get them certified. So if that's something that you'd be interested in. So I would definitely think about reaching out to your CCO if you are using, if you're using any kind of traditional health worker that's not certified. But for our program for PCPCH, we don't require it. We're not going to ask if your traditional health workers are certified or not. But for the payment piece, you definitely would want to maybe work with your CCO on that. Andrea, it looks like your hand's raised again.
Yeah, just in relation to that question, right now in the OARs, there is something called a legacy clause for each worker type. And what this is it's a way to certify your workers who are already doing the work of traditional health workers without having to take the training program. It requires documentation of so many hours of doing that type of work. They have to complete the oral health training requirement, which is like an hour and a half training that's available free online. But that's a way to get like personal health navigators, community health workers, any of the worker types certified without having to complete the training program if they already have experience doing the work. The catch is this legacy clause will be eliminated June 30th, 2025. And that will no longer be an option. So if that's something that you are looking towards doing for some of your workers, you're going to have to get on it in the next 6 months because it's going away. So just a little side note.
Good. Thank you for that. I wasn't aware of that. So that is good to know. We can think about how we might share that with our practices, the practices in the program too, more broadly than just on this call. I think that's important for people to know. So maybe in our next program update, we'll add that in. So yeah, thank you. Okay, let's see. The next question for 6E0, it said clinical staff must take a training every 2 years. If our clinic required cultural or other DEI training in 2024, would that cover the requirement for 2025? Yes. Yeah, that's totally fine. Yep. Yes, that's a good question. Okay, great. It looks like somebody mentioned NEON, which we're definitely aware of that group. That we actually saw them present at the Oregon Rural Health Conference. They're really great. And Meg put thanks Meg for popping that in the chat. That's Meg's neck of the woods. She lives over in Joseph. So yes, as that person mentioned, thank you, Lindsay. They offer different types of trainings as well. So if you're in that area, I would really encourage you to reach out to them. They were really great, actually. So, okay, let's see. There's another question. There are lots of different examples of traditional health workers listed. Can you please explain more about what service each one provides? So let's see. So we do have, I did put something in the link. I did put a chat. I did put in the chat a link to the website. I'll just add that back in here that has the different categories. And there is a little bit of information in there about what each, at least a description of, I'll just put it down here, a description of what each worker type is. But as you've heard from several people when we're giving the examples, you really can utilize these different traditional health worker categories in whatever way makes the most sense for your practice. So I would really encourage you to start with that and just think about how might that particular person, given their scope of work, how might they be able to meet the needs of your patients? Does anyone have anything to add about that, Kamar? Yep. Good.
Yeah, I did. Sorry, I'm off camera because my internet. But I did. OHA actually has all the explanations or links of the different types and what they do and so forth. So I did put that link in there. Yeah.
Oh, good. Thank you so much. Good. Great. Okay, it looks like somebody added a UHA billing guidance document for those who are interested. Okay, great. Thank you for adding that. A video from Orchwa, great, about the so some good resources that folks are putting in the chat. Thank you so much for that. A learning collaborative, endorsement for a learning collaborative, great. So, okay, good. Some more resources for children with special health needs, Oregon Family to Family. For children, we often put families in contact with Oregon Family to Family. Is that something that would qualify? I'm not familiar with that specific program. Does anyone else? Is it part, Meg, I see you added a link to it.
Yes, it's through OHSU.
Uh-huh.
And it's a connection of between, families that have special needs kids and provides resources. So it is an informational center.
Yeah, we would have to take a closer look at that and figure out if they're actually providing like peer services. I assume probably the peer services would be most appropriate in this case in terms of a traditional health worker category. It'd be, family to family or peer, like peer-to-peer, like somebody who also has children with special health needs working with your patients. So we would have to take a look at that.
Sure. I'm happy to look into this too. It looks like they assign a parent partner.
Oh, great.
So we'll see. Yeah, we'll look into peer. I think it could be a good peer support. So thanks. Thank you so much to Charlene. Hey, thanks for posting that. So I'll dig into that for the team. Yeah.
Thanks, Meg.
You're welcome.
Just to add on that, keep in mind that any external partnerships, we do expect there to be some coordination with that group. So for example, if you look on page 161 under activities that do not meet this measure, it says a practice refers patients to an external agency with traditional health workers, but does not communicate or collaborate with the traditional health workers to facilitate patient care. So that coordination piece is important.
Great, thanks.
Yes, thank you for highlighting that, Rachel. Let's see, link to OHA's toolkit. Yes, great. Okay, and then it looks like there's a question here. Does PCPCH have any guidance on the ratio of community health workers to providers for the total assigned patient population? That's a good question. I don't know of anything. We have not come across anything in our, when we were writing this standard about what type of ratio would make sense. I think that's probably going to be a bit dependent on your patient population and what their needs are and who you're serving with that community health worker. And I don't know. I'm not sure if there's any even evidence base around any research that's been done on that about what a ratio might be. I'm not sure. I'm looking to the team to see if anybody knows of anything.
Yeah, just to add to you, Amy, what you said, I don't know of evidence base as well. We can look into it. But when I was in the clinic, there were 4 teams, and there are 2 of us. That was kind of each, THW or CHW in our case was that we were responsible for, 2 initially, but then really we were just working together on all of them. So 2 worked out for that clinic, but some clinic also had 3. Again, maybe it's just like you said, Amy, your population, what your needs are, what you're experiencing. You might start slow and then you might, see that you need a bit more. Or your providers, depending on how you're utilizing the different roles.
Mm-hmm. Great. Thank you for adding that, Kamar. I appreciate that. Andrea, she just restated that. She said, once you have them and start using them, you'll find you never have enough.
Yep.
I imagine that's true. We've heard that with behavioral health providers as well. Like once you have a good behavioral health provider integrated in primary care, you don't ever want to go back. So I imagine the same is true for community health workers and traditional health workers. So all very, very important parts of the care team. So great. Well, I think those were all the questions in the chat. Did anybody have a question that I skipped over by mistake or? So, looks like another one came through. Oh, okay. So yeah, Lindsay says she has community health workers assigned to care teams within a family practice setting, each working with 2 to 4 medical providers, and highest performing work with 500 to 800 unique patients a year. Tenure allows for greater engagement with the panel, and yes, we do not have enough. So Oh, yeah. Great. Any questions I skipped over or things by mistake or any other comments or questions people want to add? Oh, that's good. Thanks. It looks like Mike did a couple quick checking. And it says for population estimates, so population, 1 to 10,000 community health workers for HRSA. So that's what HRSA recommends. Again, population. And then for rural, 1 for every 2,000. Yeah, good. Thank you for doing that. HRSA is a good resource for that information as well. So great. Okay. Well, that was a really great discussion and lots of great questions. And I'm so thankful for those of you who joined and contributed by answering questions. It's so helpful for us to have those true experts on the call with us. So thank you so much. And I hope that you will join us for our next webinar, which is about the health equity designation. That is at the beginning of December. I think it's the 6th. I'm actually presenting that one. I should probably get on that. So I think it's the 6th. So thank you very much for coming today and hope you'll join us for the next one. And I hope everybody has a terrific weekend. So thank you so much.